Good evening and welcome everyone. Welcome to our the Nevada Minority Health and Equity Coalition Amplifying Equity webinar series. It is part of our work in our community in Nevada to continue to address the issues happening around the COVID-19, the pandemic. Obviously, at least it looks like we're now getting through, going to the other side of this, but there's still a lot of work to be done and a lot of initiatives that need to take place. Part of our effort with the Amplifying Equity series is to continue to provide education, information, and the people being connected where they need to be in order to do what they have to do to continue fighting against the COVID-19. As you all know, the numbers are not good in the sense of who we've lost, people who've gotten sick, and the populations that are inequitably impacted by the COVID-19, which obviously the ones that are at the top, unfortunately, are Black, African Americans, our Latinos, our Native American population here in Nevada. At times, the Pacific Islander community has been hard hit. So it still takes all of us working together. Part of our work during this past year is the One Community campaign, which was initiated through CARES Act dollars, which helps fund some of these webinars, helps provide the work that we do, support the work that we do through the Amplifying Equity series, through all the things that we need to be doing as a community to come together. Tonight's program is part of our outreach and work with the African American Black community. So I'm so grateful to the folks that are joining us tonight, but their introductions will come in a little bit. Let me first start by thanking our sponsors, Delta Sigma Theta Sorority Incorporated, Las Vegas Alumni Chapter, Nevada Minority Health and Equity Coalition, the UNLV School of Public Health, Dr. Katrina Halsett. She's been phenomenal working with everybody and bringing this group together. Thank you. Nevada, and our moderator tonight, Will Rucker, Compassionate Las Vegas. I'd also like to send a big shout out to Pam on our board. Pam, you've done a phenomenal job. Pamela Atkins Gerard, who's gotten everybody connected and brought some incredible people together tonight for this webinar. So thank you, Pam, for that. Again, this will be the first part of a three-part webinar event focused on the impact of COVID-19 on the African American community. Please be sure information will be at the end of this. There will be information, or there will be in the chat box for folks to register for the upcoming events. The next event will be on April 21st, and then the third event will be on May 19th. So please join us for those. You can also go to our website, the Nevada Minority Health and Equity Coalition website, which is nmhec.org/events, and you can register there for those events. So with that being said, we have a couple of guest speakers who are joining us tonight first to make some comments. And so it is my pleasure to introduce a friend, a colleague for a long time here at UNLV. I'm so proud. She finished her pathway and started on a new one with her PhD. So it is my pleasure to introduce Dr. Rebecca S. Rogers, who has her doctorate in workforce development and educational leadership. Currently, she serves as the first vice president of the Las Vegas Alumni Chapter of the Delta Sigma Theta Sorority Incorporated. Dr. Rogers, take it away.
Good evening, and thank you, Jose, for that warm welcome. As mentioned, my name is Dr. Rebecca Rogers, the first vice president of the Las Vegas Alumni Chapter of Delta Sigma Theta Sorority Incorporated. On behalf of our chapter president, Belinda Morentic, I would like to welcome you to this kickoff event for this special three-part series, Fact vs. Fiction, Fighting COVID-19. As we recently crossed the one-year mark of the COVID-19 pandemic, it is imperative that we continue to stay informed and, more importantly, stay safe. We are excited about this series. Thank you to our panelists, Dr. Kane, Dr. Lipscomb, and Dr. Dial, for agreeing to be our presenters. Last but certainly not least, thank you to our community partners, Nevada Minority Health and Equity Coalition, UNLV School of Public Health, Katrina Haslett, MD, Health Plan of Nevada, and Compassionate Las Vegas for partnering with Delta Sigma Theta, the Las Vegas Alumni Chapter, to host this series on this very important topic. Again, welcome and thank you for taking the time on this Wednesday evening to join us. I hope you enjoy this series.
Thank you, Dr. Rogers, for your remarks and for being here tonight. Hello, everyone. I am Reverend Will Walker, and I am excited to be your moderator for today. Even though I am from Detroit, I earned my master's degree from a school in Virginia, completed ministry school in Texas, and direct health promotions for the American Lung Association from Michigan to Hawaii. Las Vegas has my heart. You may watch Compassionate Las Vegas, the podcast, or listen to A Healthier Tomorrow on KCEP. But tonight I am here, and it's all about one community, our community. Now, I have been personally affected by COVID-19 and faced, like many of you, some very real challenges during this pandemic. So that's why it's not only my honor, but my duty to be here tonight. So before we get into the panel, we have another very special guest who wants to share with you. Congresswoman Dina Titus is joining us by video now. Please take a look.
Hello, I'm Dina Titus, your Congresswoman for Nevada's 1st District in the heart of Las Vegas. I'd like to welcome and thank you for being a part of this incredibly important conversation between UNLV's School of Public Health and the Nevada Minority Health and Equity Coalition. I'm honored to have the opportunity to address you about this critical topic. COVID-19 has laid bare and worsened so many inequalities that plagued our society well before this virus entered our lives. This is especially true for health disparities experienced by people from racial and ethnic minorities. That's why I joined my colleagues to support a resolution calling on federal health agencies to collect data on the racial and ethnic backgrounds of COVID-19 patients, and why I co-sponsored a resolution drawing attention to the fact that communities of color have been hardest hit by the virus. Infection rates are more than 3-fold higher, and death rates are 6-fold higher in predominantly Black counties compared to white counties. In New York alone, we saw that despite making up 18% of the community, Black patients represented 33% of hospitalized COVID-19 patients. In 2019, the average life expectancy of African Americans was 4 years less than Caucasian Americans. Unfortunately, COVID has only made these differences worse. As of 2020, there's now a 6-year difference in life expectancy between white and Black Americans. We have to close this startling gap, and we know that the disparity is in part caused by systemic racism. Beyond the pandemic, we must address inequalities in education, income, nutrition, and health care. I'm committed to leveraging every possible resource to fight this virus. That includes working with trusted community partners like UNLV to make sure everyone becomes vaccinated. I'm proud to have voted for the American Rescue Plan, which authorized $1.9 trillion to help our country crush this virus and recover from the pandemic. You may have heard about the direct payments that were in that bill, along with other targeted relief to help those who are hurting the most buy groceries and pay for rent. I hope you also know that the American Rescue Plan includes significant resources to safely return students to the classroom, including direct assistance for public institutions of higher education and for student support services. As a former UNLV professor, I can only imagine how difficult this past year has been for all of you, and I'll continue to fight to ensure that you have the resources you need to pursue careers in public health. Additionally, I was able to work directly with congressional leadership to ensure that the American Rescue Plan would factor in the local unemployment rate when distributing aid to state and local governments. In Nevada alone, that provision will provide us with an extra $1 billion to keep teachers, first responders, and public health workers on the payroll. This legislation also includes $20 billion to accelerate vaccine distribution and $50 billion to expand COVID-19 testing. Furthermore, the bill invests billions of dollars into trusted public health institutions like the Centers for Disease Control and Prevention, and it expands health insurance coverage for those on Medicaid. By letting science dictate our approach, and with this new funding, we can turn the tide on the coronavirus. The American Rescue Plan was crafted with the idea that those who have been hit the hardest should get the most help. That means minority communities must be at the forefront of receiving relief, not an afterthought. I remain committed to advocating for the resources Southern Nevada needs to not only vaccinate our community, but also to help us build back better. In closing, I'd like to take this opportunity to let people know about the services my office can provide. If you're having issues with government agencies like immigration visas, Social Security, Medicare, VA issues, please give my office a call. Our casework phone number is 702-220-9823. You can also get connected to help by visiting my website at titus.house.gov. So please just give my office a call if we can ever be of service. Thank you again for giving me an opportunity to speak with all of you. Please continue to stay safe and healthy.
Well, thank you so much, Congresswoman Titus, for that important message. Next, we are also honored to have Clark County Commissioner William McCurdy II. I call him the Commissioner for Compassion. He's here with us tonight. Please help me welcome our guest. Commissioner, you have the room.
Well, good evening, everyone, and thank you, Will, as well as the Nevada Minority Health and Equity Coalition, as well as UNLV Public Health for welcoming me to join you tonight for this incredibly important discussion. What many of you know and what the Congressman just shared is that COVID has disproportionately impacted people of color, and specifically the Black and African American communities, the immigrant communities, as well as our Native communities. But there is help on the way. What we know is that here in Clark County, we've been leading the charge to make sure that there is equity in not only the information and education that is done in these communities, the communities that I represent, and I represent Clark County Commission District D, which covers everything from Hollywood on the east side, all the way down to Decatur on the west, from Charleston on the south, all the way up to North Las Vegas, past Craig Road to Ann. So you could say that I have a majority minority community. And with that being said, my district has been hit extremely hard, just like many other areas where we have high populations of minority communities and people of color. But what we are doing is meeting people where they are, making sure that they have the educational resources that they're going to need to not only fight back against COVID-19, but also lead them on a path back to prosperity again. We have noticed also within over 700,000 vaccines that have been taken here in Clark County that not many have gone into the Spanish-speaking immigrant, Native American, and also the Black communities. And we are making sure that we are collaborating with community partners, talking to a lot of the service providers, and meeting people where they are by way of collaborating with professionals within the community that can speak directly to the concerns of the community members as well. And just this week, we launched a Back to Life campaign targeted towards the Black and African American communities to make sure that we spread awareness of this vaccine. Because as we all know, there is a long history within the community of distrust of vaccinations altogether. But we are getting that information out, letting the community know that this vaccine is scientifically proven, it is research driven, and it is safe to take. But with that being said, that is exactly why a discussion such as this is important for me to be a part of, because I too am looking to learn more so that I can share with my constituents as well. We are truly in this together, and that couldn't be more than what it is right now, because we see folks that are struggling to make ends meet. And Clark County is leading the way through some of the efforts like the Congresswoman just stated through the American Rescue Plan to offer rental assistance, utility assistance, and the like. So if you or anyone you know are experiencing hardship, maybe behind on payments and there are arrears for rental, or you need utility assistance, reach out to Clark County, because we have what we call the CHAP grant, which is the County Cares Assistance Housing Program. And we're looking forward to helping you. And you can reach out directly to my office at 702-455-3239. We stand ready and willing to help you through this difficult time. But just know that help is on the way, and we're always a phone call away. So I'm incredibly thankful to join you today. And I'm looking forward to this incredibly important discussion, and looking forward to seeing how we can further amplify equity around COVID-19 and vaccinations as well. So thank you, Will, for having me, and I look forward to this important discussion.
All right, well, thank you, Commissioner. We are absolutely in this together, and so thankful you are leading the way. Now to our audience, thank you for joining us. We're so glad that you're here. I want to invite you to use the Q&A box to submit your questions, or if you're watching on Facebook, please use the chat box to submit questions. We want you to get the information you need, and we have the experts here tonight with accurate information, important information, and it's here for you. Also, if you haven't already, share this webinar with your friends and family. Let them know it's not too late to join. Now, I'd like to welcome Dr. Kane, our first speaker. Dr. Kane is a native of Las Vegas, where she attended El Dorado High School. After graduation, she attended Jackson State University in Jackson, Mississippi, where she played Division I soccer as well. She went on to obtain her medical degree from Lincoln Memorial University in Tennessee. She completed her family medicine residency at Southern Colorado Family Medicine, where she was also the chief resident. She currently practices outpatient family medicine at the Choctaw Indian Reservation in Mississippi. Her passions include working to improve access and care to the underserved and working to alleviate healthcare disparities. And she is also a member of Delta Sigma Theta sorority. Dr. Kane, take it away.
All right, can y'all hear me?
Yes, ma'am.
Okay, all right. As he stated, I'm Dr. Charnel Kane. So my portion is gonna, basically let you all know what COVID is, discuss so we have a better understanding, and also give a comparison between the COVID and flu, and then also touch on some healthcare disparities. All right, so basically, what is coronavirus? Everybody has been saying the word coronavirus, 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 but what does that even mean? So coronaviruses are a type of viruses, and that name corona means crown-like. So they are named for the crown-like structures on their surfaces. And there are several different types of coronaviruses that can cause just mild cold-like symptoms. However, certain types of coronaviruses like SARS-CoV-2, which is COVID-19, cause more severe illness. And then when we look at COVID-19 specifically, it's a viral respiratory disease caused by SARS-CoV-2, and the term SARS, which some of us might be familiar with when we had another breakout several years ago. It's severe acute respiratory, basically distress syndrome caused by coronavirus. And it's thought to spread mainly from person to person via an airborne method through respiratory droplets. That means it can be spread through sneezing, coughing, talking, or contact with an infected person's mucus, like drinking after an infected person, kissing, things like that. And although there are several types of coronaviruses that exist, COVID-19 is considered new since it was identified in 2019. And you can go to the next one. And then we'll touch on some similarities between the flu and COVID-19. So some of the similarities include fever, which is of course high temperature, chills, cough, shortness of breath or difficulty breathing, either when you're sitting there or walking around, fatigue, just feeling extremely tired. You can get a runny or stuffy nose, a sore throat, muscle aches or body aches. You can get headaches. And either one of these, you can end up developing pneumonia, something called sepsis, and that's where an infection has started in one part of your body, and then it basically starts to affect your vital signs, and you get really, really, really sick. And then you can also end up with secondary bacterial infections. And so what that means is that flu and COVID are both viruses, but you can get so sick and have suppression of your immune system to where bacteria can also start to grow. And so you end up with two illnesses, basically. All right. And so flu versus COVID-19, some of the major differences. So with COVID-19, it can be associated with loss of taste and smell. And some people that I know I'm seeing in clinic, they're already a year out past their diagnosis and they still can't smell completely normally. And then a lot of their taste is still off. Like some patients I know said that they used to like Dr. Pepper and now they can barely taste the fizz. So it's taken a longer time for some of their sensations to return. And then COVID-19 can be associated with more severe illness, like longer hospitalization stays, worsening lung disease, more difficulty breathing, and more systemic symptoms that are affecting several different organs of the body. And with COVID-19 as well, it can also take longer for you to develop symptoms. So you might have an exposure and you feel good for the first couple of days, and then in the next couple of weeks, you start to feel ill. So you can start getting symptoms between 2 days to 2 weeks, versus with influenza, people typically start to get the symptoms between 1 and 4 days. And then with COVID-19, you also may be contagious for longer periods of time than the flu, and also may shed the virus for a longer period of time than the flu. And with COVID-19, there is an increased risk of blood clots to the legs, the lungs, the brain, and the heart. So we are seeing a significant increase in complications in patients who have had COVID-19. And so it's been really difficult to treat just because so many things can go wrong and affect so many organs. And then there's also an increased risk in children of developing multi-inflammatory syndrome in children, and the acronym is MIS-C. And so what that means is they start to get inflammation in their lungs, so it becomes harder to breathe, and some of them can go into respiratory failure. They start to get inflammation in their kidneys, so their kidneys start to shut down and not work properly. And then they can end up with inflammation in their brain. So they get some brain swelling. Some children have developed seizures. There's even been strokes in some younger children as well. And you don't usually hear of a child having a stroke. You usually hear of like an older person with heart disease having stroke. So there's a lot of things going on. And then just several other organ systems. Some people have, even in kids and adults, they've developed gangrene to where the virus has started affecting their fingers and toes. So there's a lot going on. Right, switch. All right. And then risk factors for, number one, getting COVID and worsening illness. So adults 65 years and older, or people of any age with underlying medical conditions are at a higher risk for severe infection. However, there have been several cases in young people who were previously healthy, and some of them ended up in the ICU. And then some underlying medical conditions that can place you at higher risk of developing complications include diabetes, high blood pressure, heart disease, obesity, HIV, and lung disease. And then when we look at those medical conditions, there's already a higher rate of those diagnoses in African Americans, Hispanics, Native Americans, and also in underserved and impoverished areas. And all of those medical conditions, including obesity, have a baseline of inflammation in the body. So if you're already predisposed and already have components of inflammation in your body, then you tack on a virus that causes more inflammation. You end up with a big medical conundrum of illness. So it's very important that, you know, people of color, or anybody in America, but people of color truly make sure that we're trying to understand this disease in order to help decrease healthcare disparities. All right. And so even though COVID is a disease that primarily affects the lungs, it can cause damage to other organs as previously stated. So some of the heart effects, it has been shown to destroy heart muscle tissue. And so basically it can cause the heart muscle to become inflamed and kill some of the heart tissue. And so that has led to heart attacks in several patients, heart failure to where your heart starts to not pump properly, and then abnormal heart rhythms. And then the lung effects, it can destroy something called alveoli, which is little air sacs in your lungs. And so that causes scarring, and you can't really recover from scarring. And so a lot of them end up with long-term breathing complications. I've been seeing some people now that are still on oxygen several months out. And if they take off their oxygen, they still desaturate, or their oxygen still drops too low. And then you can also have effects on the brain. And so in some people, they now call it COVID brain fog, to where after you recover from COVID, you just don't have the memory that you used to. You just start forgetting things, or sometimes you can be mid-sentence and then your thoughts will just leave you. So it's been associated with memory problems. And then it has caused strokes and seizures in some patients. And then I also want to say, I know a lot of people have been saying, you know, coronavirus has been around for forever, but the difference with this is that it's more dangerous. So I know a lot of people have been looking on, you know, the back of the Lysol can. It's like, well, there's coronavirus. Yes, there are several different types of coronaviruses that have been around for a while, but this one is more deadly. It affects the body in different ways that we just don't see that often. So I do hope that people continue to take it seriously.
All right. Thank you, Dr. Kane. So my name is Justina Lipscomb. I am a clinical assistant professor at the University of Texas, and actually I'm in San Antonio, Texas, but I am still a part of the Austin, Texas University system. And I am also a internal medicine pharmacy specialist at Methodist Hospital in San Antonio. And so I have the pleasure of talking to you all about the COVID-19 treatments. And what I will say is that I'm going to try to make this as painless as possible. So our first thing that I want to talk about with all of you guys is the outpatient, or the treatments that we do outside of the hospital stay. And the first thing that I'm going to mention is just infection control. Then I'm going to talk about some monoclonal antibodies, which includes bamlanivimab, etesizumab, and I'm going to call that BE because although I am a pharmacist and I should know how to pronounce these names, they do get a little tongue-tied, or I do get a little tongue-tied with them. So I'm just going to call it BE for tonight. And then I'm going to talk about convalescent plasma. So our first thing that we should all do is, if we have COVID, we should isolate ourselves. And isolation essentially means that we isolate ourselves from others without COVID. So isolation is used to separate those with known COVID disease from those without COVID. And it is recommended to isolate from others for at least 10 days from symptom onset or from the date of testing positive from COVID. Please keep in mind that symptom resolution varies from person to person, and so does complete recovery from COVID-19. And most patients with mild diseases will recover within 2 weeks, but some patients will take a little bit longer to recover. And if you have more severe disease, it may take you up to 3 to 6 weeks to recover. And therefore, if you are still having symptoms such as trouble breathing or trouble doing activities that you normally do, or if you're still having fevers for more than 24 hours, please, please, please isolate yourself. So our next thing is symptomatic treatment. And so symptomatic treatment is going to include using agents such as acetaminophen, which is also more commonly known as Tylenol. And this is going to be mainly for fevers, muscle aches, and headaches. And acetaminophen or Tylenol is what is preferred for symptomatic treatment. However, if your symptoms do persist, you can use non-steroidal anti-inflammatory drugs or NSAIDs, such as ibuprofen and naproxen. Also, for patients who are having persistent cough, there is a medication called dextromethorphan, which can be found within your local pharmacy. It is available over the counter, so you can purchase it from your local pharmacy. Or if you need something a little bit stronger, benzonatate, which can be provided as a prescription from your provider, can be used for persistent cough. Another thing that can be done for persistent cough is what we call self-proning. And essentially, as you can see with this picture right here, it is just changing positions every couple of or every about 30 so minutes until you get comfortable. And so this has been shown to help with persistent cough and breathing. Other things can be breathing exercising, which are especially useful for patients with lung disease. And then hydration is really important. So making sure that you are getting enough fluids, especially if you have fevers and things like that. So making sure that you're staying appropriately hydrated is going to be important. And then rest, especially in acute illness, is important. And then as soon as you are able to get up and walk and ambulate, we do encourage that. So I'm going to talk about bamlanizumab, etesizumab, and the reason why I'm not really touching on the other monoclonal antibodies that I mentioned previously is because this is the one that has actually been shown to reduce risk of death and hospitalizations in the outpatient setting. And so per the guidelines, the two together, which I'm going to call BE, should be administered in combination for patients who have mild to moderate COVID-19 disease, or in those who test positive and who are at high risk for progression to severe COVID-19. And so those that are at higher risk are those that are obese, those that have chronic kidney disease, those that have diabetes, who are immunosuppressed. And so when I say immunosuppressed patients, I'm talking about patients that have HIV, cancer, or the patients who are on chronic steroid use for whatever disease state. And then patients who are older than or equal to 65 years old are at higher risk. And also patients who are older than or equal to 55 years old with hypertension, diabetes, or any other chronic lung disease may benefit from using the BE combination. And essentially this combination is given as a 1-dose single injection. It should be given at a clinic, and it should be given within 10 days of symptom onset. And then finally, for outpatient therapy, we have what is called convalescent plasma. And essentially what this is a very concentrated blood product that has the COVID antibodies. And so patients who have had COVID-19 can donate this blood product, and it can be given to patients that are acutely going through COVID-19. And what it has shown is that it has reduced hospitalization and it has reduced death, particularly in those patients who have not already been hospitalized. And also it has been more beneficial in patients who are at high risk, specifically those patients who are 75 years or older, or those patients who are 65 years or older with the comorbidities that I spoke about earlier, such as hypertension and diabetes. And I just want to touch briefly on some of the inpatient or the therapies that can be given in the hospital setting, such as steroids, particularly dexamethasone, which has shown some benefit in patients who are requiring ventilatory support, so additional support for breathing. And then we have remdesivir, tocilizumab, which again have been shown to be beneficial in patients who have dropped their oxygen levels. So when you put that little thing on your finger, I don't know if you guys have done this, but we do recommend using this little thing that goes on your finger to test your breathing. Once your breathing gets to a certain point, and if you are in a position in which you need hospitalization, these two, remdesivir and tocilizumab, have been shown to be beneficial. And then finally, we have the plasma, which has shown more data in patients who are in the outpatient setting, but can and may be beneficial in patients who are in the inpatient setting, particularly within 3 days of showing symptoms. So other therapies do include antibiotics. And I do want to point out, as a pharmacist, I'm sorry, but I do want to point out that antibiotics should not be used for prophylactic use. And what I mean by prophylactic is preventative use. They should only be prescribed to you if you have a concurrent or a active bacterial pneumonia infection, which has been shown to be common with patients with COVID-19. And then the combination of hydroxychloroquine and azithromycin, you may have heard about this combination with the person who was previously in the White House. He really pushed this combination. However, it is not recommended. There's no clinical benefits for it to be used. And it has shown more harm than benefit, especially in patients with heart issues. And then finally, we have vitamin D therapy or zinc therapy, which may be appropriate. It may be beneficial. There is limited data showing that showing its benefits. But one of the things that I do want to mention is that we should not exceed upper levels of doses if you are using this. All right, so I'm now going to pass it off to Dr. Dale.
Hi, everyone. My name is Dr. Yawandi Daya, and I'm currently practicing as an infectious disease pharmacist in New Orleans, Louisiana. And I'm going to talk to you real briefly about the COVID vaccines, and I'm going to focus on the ones that we actually have currently in the US, and just walk through how they work and what we can kind of expect from them. Next slide, please. Thank you. So the first COVID vaccines that were released in the US or approved by the FDA use this technology called mRNA. So we have two of them. The first one's the Pfizer-BioNTech vaccine, and then we have the Moderna vaccine. They're both 2 doses. The Pfizer-BioNTech vaccine is a 21-day time to get the second dose. And then for the Moderna vaccine, you wait 28 days and then you get the second vaccine. In terms of the studies and what we've seen so far in all the people that have gotten the vaccines, no major safety signals in the sense of we haven't noticed anything that is concerning enough where we would have concern about the safety of this vaccines. However, for patients who have had a severe allergic reaction to the vaccine ingredients, for most patients, that usually is polyethylene glycol. That's the most common allergy that we've seen. The recommendation by the CDC, FDA, and the manufacturer is essentially to avoid these vaccines if you've had a history of severe allergies to them. In terms of the efficacy that we know from the studies that were used to essentially approve these vaccines, they are about 97% to 100% effective at preventing hospitalization, about similar effects for severe disease. So severe disease is what usually gets people into the hospital. In terms of death, the vaccines and their trials, nobody died that got the vaccine. So 100% essentially is the ability of this vaccine to prevent death. And now we have more data that's showing that even for patients who have gotten the vaccine, it does protect them also from getting mild disease up to 94%. Next slide, please. So how do these vaccines work? So they use the mRNA technology, as I mentioned, and essentially this is something, the mRNA piece is something that was designed in a lab, and basically it's a string of codes essentially, and they're encased in something called lipid nanoparticles. And the purpose of the lipid nanoparticles is to kind of stabilize that mRNA, because otherwise what your body does, because we produce mRNA, it's a part of our daily lives. What your body does is once there's mRNA that's kind of floating around in your cell, the body will chop it up. So in order to have this mRNA vaccine deliver the vaccine before the body chops it up, it is encased in lipid nanoparticles that are kind of similar to what we have in our body. And that helps it get through into the cell without the body destroying the vaccine before it's able to do its job. Once the mRNA piece is inside of the cell, your cell basically is able to read that mRNA, and it gives your cells instructions on how to make the SARS-CoV-2 spike protein. So if you've seen pictures of the SARS-CoV-2 virus, it has these red spikes just sticking up of it. That's what the mRNA vaccine is telling your body to make, because this is unique to that, to the coronavirus that we are dealing with right now, and we don't have spike in our bodies. So once your body makes these spike proteins, your body, your immune system essentially recognizes that these spike proteins should not be there because we don't have spike proteins. And it comes up and it triggers an immune response where your body comes and tries to fight that spike protein. Your body comes, destroys that spike protein, but in that process, it also learns how to fight the spike protein in the future. And that memory is stored in what we call essentially our memory B cells. And that kind of goes and chills somewhere else until you come across the coronavirus again, and then your body comes up and fights it again. Next slide, please. Thank you. So something that I thought was very important to highlight, and I really liked this slide to help spread this really well. One of the major concerns that people have is, will these vaccines change my DNA? So I think this is a really good way to explain how it cannot possibly change your DNA. So in the body, when we have typical processes going on, there's one pathway that usually happens. You have DNA that transcribes, that puts out mRNA, and mRNA basically tells the body how to make a protein. So a very good analogy for this is if you go to a restaurant, you get presented with the menu. You read the menu and you place your food order, right? When you place your food order, the waiter goes in the back, puts your food order in, and then your food comes out. If your food comes out and you don't like your food, you can change your order. So that is analogous for the manufacturers of the vaccines can tweak things in the vaccine to modify as we get these new variants. However, what never happens is because you don't like your food, the menu that you started with doesn't change. The restaurant will not change their menu because you didn't like the food that you got, but they can change your order though. And so that's a good way to kind of highlight that mRNA does not go back to DNA. That's just not how the body works. It always works DNA to make mRNA to make a protein. Next slide, please. So the next one I'm going to talk about is the technology called the non-replicating adenovirus vector vaccine. And I'm going to walk through the mechanism of how that works. So this is the Johnson & Johnson, or what we call the J&J vaccine essentially. And it's basically a modified adenovirus. So adenoviruses are viruses that we get exposed to them. Sometimes when you get the normal cold, it could be caused by an adenovirus. So they're kind of present a lot in our day-to-day life and in how we kind of interact with each other essentially. And so what the manufacturers of this vaccine have done is they've taken a slightly different type of adenovirus that your body has never been exposed to, so that your body doesn't have antibodies to this particular type of the adenovirus. They've taken it and they've made sure that it cannot replicate. So if I inject you with these adenoviruses that that are in the Johnson & Johnson vaccine, it cannot infect you and go ahead to cause another infection because it cannot replicate. And that's a fundamental process in the ability for any pathogen to cause an infection. So that's the first step. The next step is they've taken the gene in the coronavirus that makes the spike protein, and they've inserted it into this adenovirus. And so essentially when this adenovirus is injected into us through the vaccine, it essentially uses your cells, which is what viruses typically do. It uses your cell to then make that spike protein that we've inserted into its gene. Once that spike protein is produced, the same process as what happens with the mRNA technology vaccines happens. Your immune system sees it, it fights it, and then it learns how to fight it in the future. Next slide, please. And so these are, I guess, some national and local resources. I think Justina is going to talk a little bit more about this, but if you have any questions for me specifically about the viruses, please put them in the chat box or ask them. Thank you.
Yeah, so basically, the Centers for Disease Control and Prevention, if you have any more questions, or if you, before now in our next presentation, if you have any more questions about the vaccines or just coronavirus in general, you can always get some good information from the CDC website. Also with the National Alliance on Mental Illness, COVID-19 resource and information. I know that a lot of people have struggled with essentially being isolated in general from others. So this has some good tips and advice for people who are struggling overall. The government response to coronavirus, the USA.gov website has provided some information, some real-time information about coronavirus. And then some more local resources are the Nevada Health Response and the Vegas Strong Resiliency Center that can provide some good information. And then again, at this time, we'll open it up for questions. And I do want to thank everybody for participating and joining us tonight. This is something that we are all passionate about. And we do have part 2 coming up where we will dig a little bit deeper into the hesitancy within the vaccinations and then also talk more about the vaccinations.
Thank you so much, Dr. Lipscomb, Dr. Dayo, Dr. Kane. Everyone provided such rich information that Lysol can definitely resonates. A lot of people were talking about that. So the way you explain risk factors and effects and treatments and vaccine and just what the coronavirus is really makes it easy to understand and for us to take seriously. Before we get to our next section, we would like to thank and give a special shout out to the Physical and Mental Health Committee of the Las Vegas Alumni Chapter of Delta Sigma Theta Incorporated, which is chaired by Dr. Katrina Haslett, MD. This event would not have been possible without the hard work of this committee and Dr. Haslett. So thank you. Now we have some great questions coming in through the Q&A box here on Zoom and in the chat on Facebook. So keep them coming. We're going to ask the panelists for their responses. But before we do, I want to take a moment to just go over the COVID-19 updates for the state of Nevada. So if you could please share those slides. All right, so state of COVID-19, who is eligible? Well, effective March 22nd, 2021, majority of groups are eligible except healthy adults 16 to 64, NDOC inmates and transitional offender group housing, frontline commerce and service industries, frontline infrastructure, and other categories. Effective Monday, April 5th, Eligibility to receive the vaccine opens to anyone, that's everyone, age 16 and older. So that's everybody that's not in that previous category. You can schedule or cancel appointments through the state of Nevada helpline, which is at 1-800-401-0946. They are available 7 days per week, 8 a.m. to 8 p.m. The Health District Clinic does reserve appointments for people 70 years of age and older, and those with mobility issues. For current health district and partner points of distribution, go to www.snhd.info/COVID. You can also visit immunizenevada.org for more information. If you need support, ask a question. Contact the State of Nevada helpline. Again, that number is 1-800-401-0946. And they are available 7 days per week, 8 a.m. to 8 p.m. Beginning in mid-April, homebound seniors will have access to in-home vaccine administration, so they do not have to go anywhere. Vaccine strike teams will be mobilized based on zip code to schedule a home visit. And lastly, check the Southern Nevada Health District social media pages. So, Facebook, Instagram, that sort of thing. We're really hip here. We do these social media updates, and you can find out about same-day vaccine availability. So you can literally walk in. All right, so I hope those updates were helpful for you. We've gotten a few more questions in the Q&A box. So I want to invite all of our speakers to turn on their cameras for the Q&A segment of this event. We have some great questions from the community. I do encourage you to continue submitting questions via Q&A on Zoom or through the chat and comment on Facebook. All right, so our first question is, many of our community members are concerned about how fast the vaccine was developed. Can you explain how they developed the vaccine so quickly?
So I'm gonna actually punt this question to Dr. Dio in a second. However, I do want to say that, especially with the 2 vaccines that we had originally, the mRNA technology is nothing new. I think that sometimes we hear novel or we hear new technology. However, this technology has been out for a while. I think that COVID solidified its place for it, but it's not anything that was recently developed. And I think that's just a misconception that I wanted to point out. And we'll definitely speak more about that on part 2. But like I said, I'm gonna punt it to Dr. Dow right now.
Awesome. So that is a really, really good question. And I will say that that's a question that I can totally relate with, because before we got all the details about the vaccine and what was in it and all the studies, I think this was a concern that even those of us in healthcare, those of us that work in the infectious disease space, we were concerned about that. But since the vaccines come out, we've spent a lot more time, or they've released basically a lot of the information to help us make this decision better. And so to answer the question of why or how did this vaccine come out very quickly, I'll first start by talking about what a typical process is for a vaccine to come out, right? So vaccine manufacturer essentially thinks they have a good candidate, and they spent time doing research, and there's so many phases of research. They have to get approval from the FDA for all the different stages of their research. It has to be funded by somebody. It depends also on the priority of that organization. So is this something that they really want to invest a lot of money in, or do they not want to invest a lot of money in? And so that usually is a huge factor in why typically when we deal with vaccines, or when we've dealt with vaccines in the past, they've taken years from start to finish to actually come to market. So how does that contrast with COVID, or the COVID vaccines that we got them in about, I think it was like 7 to 8 months, if I'm correct. It's important to kind of put into context the fact that we were in a pandemic and the world stopped. That's the first thing. The world stopped. The urgency was there. The federal government essentially threw money at these companies. So that's one hurdle crossed, is the money piece. Who's going to fund the vaccine? Who's going to fund the trials? The federal government offered a lot of these companies a lot of money to essentially fund this. In addition, because the world stopped and we were in a pandemic, a lot of person resources. So we had collaboration with the government, with private entities in America and across the world. So if you look at the Pfizer vaccine is actually a collaboration with a German company. It's not a purely American product. It's with a German company. AstraZeneca was made in the UK. And there's so many other vaccines in so many different parts of the world. And so there was a huge amount of collaboration in trying to get this to be something that we could use. China had experienced the virus first, and so they had the heads up, or they had some time to essentially work on the virus and be able to sequence the virus. And that told all the manufacturers, all the scientists that were working, this is what the virus looks like. And because of previous experiences that we've had with SARS viruses, so when we had the SARS pandemic and we had the MERS epidemic in the past, we got some experience from that. In addition to the fact that, like Justin had mentioned, we had been studying this mRNA technology for years and years and years. It goes back up to 30 years of somebody trying to figure out a way to use this effectively in humans to treat things. When you put all of that together, the fact that the US government poured a lot of money into it, the fact that the FDA essentially pulled away all of the red tape that is typically involved in making a drug or vaccine, that's how we were able to get here faster, because we all put our minds to it worldwide to get here. And that's something that usually doesn't exist in typical times.
Thank you so much for that response. And what I heard you really saying is it's kind of like an overnight sensation. You know, people work their entire lives to end up an overnight success sensation. And it seems to be the same with this technology that's been around for 30 years. And now here we are with the money, resources, and people to make it appear that it happened really quickly. So thank you for clarifying that. A follow-up to that question is, what percentage of people that are receiving the vaccine do experience severe side effects?
In terms of severe side effects, I mean, that number I don't have off the top of my head, but what I will talk about is the differences between what a lot of people think are side effects and what are really not quite side effects, right? So very commonly when people get the vaccine, you get the arm pain. Some people get fevers, some people get migraines or headaches, some people feel very fatigued for a couple of days. Those are not side effects. Those are what we call immunogenic effects or reactogenic effects. Essentially, this is what it feels like when your immune system is fighting. It means that your immune system is fighting. Your immune system is reacting to the fact that these spike proteins have been in your body now. It doesn't recognize them. It's going to fight them. That's what it feels like. It's very similar to what it feels like when people get COVID, but it's not COVID itself, because you never end up having, you don't test positive, you don't end up in the hospital from it, and you don't die from it. So that's the first thing to kind of highlight. In terms of side effects, there's been a lot of what I will call case reports, where somebody had some neurologic something, somebody had some blood clots. That's more commonly been described with the AstraZeneca vaccine. The one common thing is none of these side effects have been tied to the vaccine. A lot of them, when they've compared the frequency that these effects have happened, whether it was a stroke, whether it was a blood clot, whatever, you compare now. So in real life, typically, we get 5 people a year, for example, that get strokes. Regardless of what happens, they could be sleeping for 5 days and they get a stroke, right? They didn't do anything, they just got a stroke. You compare that typical rate to what is that rate now in people who have gotten the vaccine. And for you to be able to prove or say that the vaccine is actually what's causing it, you want to see way more than you typically see with the vaccine than without. And right now, we haven't been able to find any excessive rates or any rates that we can attribute to the vaccine that isn't similar to what the typical rate is if we were not in the situation that we are now. So none of the side effects that have been in the news have really been tied to the vaccine. They've all mostly been ruled as coincidences.
Thank you. We've got a few more questions along the same lines, but we'll come back to those. I want to turn to Dr. Kane and ask this. How do we know that this vaccine is safe and effective for minority communities? And part B of this is, since COVID-19 has exposed the racial health disparities and heart disease, diabetes, et cetera, what steps, if any, are being taken to address the disparities?
So I'll say, so number one, the vaccine recently started rolling out. And the difference with vaccine and healthcare this time around, I know I've seen a lot of people reference like the Tuskegee syphilis experiment and, things like that. But if you look around, there's also like a larger number of Black healthcare professionals also getting the vaccine. And when you look at how COVID is attacking, Latino populations, Black populations, at this point, the benefits outweigh the risks. And, a lot of people got to do, a lot of, I use the term soul searching, because you do have to research, you do have to read, you can talk with your provider. But at this point, so many lives have been lost. And people, like, COVID has not disappeared. It has not decreased. It's still going on. And so I would say just trust science this time around. I know it's difficult because besides the history of the Tuskegee syphilis experiment, there's disparities in the healthcare system that were already existing pre-COVID, that were already being brought to light. And now this is just making it even worse. I would say in this point, trust science, because we don't want to continue this high rate of death. And then can you repeat the second part of your question?
Just what is happening right now to address the disparities within the community?
Okay, I would say right now, I feel like a lot of providers of color and even providers not of color are actually going out into the communities more, or being more vocal about what is going on. And there are some states, like I'm in Mississippi, and so there are some states that are actually targeting populations and setting up vaccination sites and trying to improve healthcare access in those neighborhoods. So to try to build a better bond, so that way people do start to trust the healthcare system more, despite the history that has gone on in this country.
Well, thank you for sharing that. And if you're in Mississippi, it's kind of late at night for you. So thank you for being with us. Really appreciate it. Dr. Lipscomb, this one is for you. Why is it important for those with underlying health issues to take the vaccine?
So essentially, those with underlying health issues, specifically diabetes, heart disease, suppressed patients, they are at higher risk for actually dying from COVID. And therefore, because the vaccines have shown such a low rate of leading to death and even severe disease, it is essential that they take it, because this can be a matter of life and death. It can be a matter of getting mild disease versus severe disease. It can be a matter of eliminating a hospitalization stay. So therefore, with that being said, if you go ahead and take the vaccine, your chances of being hospitalized, or your chances of having those long-term effects from COVID, or even dying from COVID, decreases significantly. And therefore, I highly advocate that if you do have risk, you do have those high risks, that you go ahead and take the vaccine. And then I'm sorry, but I do want to kind of piggyback off of what Dr. Kane was saying earlier, and just kind of give some of the data behind the studies. So for the Moderna trial and even the Pfizer vaccine, the patient population for white Americans who actually were involved in these studies were about 80%, compared to only about 10% of African Americans in these. And therefore, what I want to say is, like, I know we have hesitancy. I know we worry about being experimented on, but when both of these trials have been looked at in more than 30,000 patients each, we're not being experimented on. These trials have been proven to be beneficial in all types of populations. And therefore, I kind of just wanted to kind of throw out some of those data, those stats, because I feel like it's important to know who these trials were actually studied on versus, you know, are we being guinea pigs? We're not. We're not at this point, so.
Yeah, thank you for adding that. That's so important. You know, we are rightfully suspicious, and it's okay to be suspicious and concerned. And that's why people are on the webinar tonight, so they can get accurate, real information. So thank you for sharing that. The next question is really open to the panel. If someone is not clear if they've had a past infection, so if they're not sure whether they had COVID-19 or not, and they do want to find out in case of managing some of those long-term effects that you talked about, do you have any information about mechanisms in place to allow for testing for previous infection?
Yeah, so they can contact their provider or contact a healthcare center to get something called a COVID antibody test. And if that comes up positive, it means you likely had a previous COVID infection.
So just contacting the healthcare provider and they can get that set up?
Yeah.
Perfect. And on the other end of this is what happens if you do not get your second shot within the allotted time?
The CDC guidance on that is essentially, ideally, we want you to get it within the time frame that it was studied in. However, if you miss that, just get it. Essentially, just get it when you remember, when you're able to. There isn't that much data right now to say, oh, get it at day 30 and then come back at day 50 or whatever. So right now the guidance is just to get it. And right now we are continuing to study these vaccines. We're learning so much more about them every couple months, every couple weeks. And so I think we will have a lot more concrete answers soon. But for right now, if you miss your window, just schedule the appointment when you can and go ahead and get the vaccine.
Perfect. So they don't have to start the process over. They just continue from where they left off. Wonderful. So we have someone that wants to hear about the Lysol. I mentioned, you know, my concerns and having heard people reading the Lysol cans. So if you don't mind just going over what the coronavirus is and why it's showing on those cans, even though it's new, you know, COVID-19 is new.
Okay, so I'll go over that. So basically coronaviruses have been around for decades. Like there's like 4 different categories of coronaviruses. That's just like a subset. But COVID-19 is considered novel/new because it was first found in humans in December. And so it's like coronaviruses are not brand new overall, but this type is. It's like you have a brand of sneaker and you get a new colorway. This is the new colorway. And so that's why there's coronavirus on a Lysol can, because they've been present, but there's a new one.
Thank you. So it wasn't, as they say, a plandemic. Is that what you're telling us?
Correct.
Okay. Thank you. Just had to get the clear information out for the folks. So, all right. The last question that I have in the chat here is, how long after giving birth do you recommend getting vaccinated?
So you can get vaccinated right after birth. Currently, there are pregnant women being vaccinated, and they're still studying them after they get vaccinated, but you can get the vaccine right after birth.
So with pregnancy, they can actually be vaccinated during pregnancy as well, if they choose?
Yep.
Okay, wonderful. And I think—
Can I piggyback off of that real quick?
Yes,
we actually do now have some data in pregnant women in getting the vaccine. So if you've gotten the vaccine, the CDC asks you to essentially sign up for this app, and then they call you and then ask you questions, and based off of your answers, they ask you more questions essentially. And so since the vaccine's been out and we've been given it, they've actually been able to study 30,000 women, I'm sorry, who either got pregnant after they got the vaccine or were pregnant by the time they got the vaccine. So it was at least within 30 days of getting the vaccine, you were pregnant. And the CDC studied that population, and essentially they compared their outcomes with their pregnancy and their births to people who did not get the vaccine. And it hasn't caused, or it did not show anything concerning. So the American College of Gynecology, that's who essentially guides how we treat pregnant women a lot in the US, they do recommend that if you're pregnant, you should get the vaccine if you want. And we actually are now also starting to see some data. It's not a lot. It's not enough to say for sure this happens, but there's been a few pregnant women who had their children and the babies actually had antibodies to the COVID virus, which we attribute to the mom getting the vaccine.
Thank you. That makes sense. We did get a follow-up to the question about the antibody test. So if you've been vaccinated recently, does the vaccine lead to a positive antibody test? And is there a time period that a person needs to wait post-vaccine to do the antibody test?
I can answer this. An antibody test will not pick up the vaccine. So you could get the vaccine and then go get the antibody test and it comes up negative. It doesn't mean you're not protected. And the reason why is because there are different types of antibodies. And the type of antibody that the tests that we have right now are testing for are not necessarily the ones that are triggered by the vaccine. The antibodies the antibody tests that are present are only able to pick up antibodies to a specific component of the actual virus. The vaccine is not the virus, so it will not come up on an antibody test. So if you get the vaccine, it's not quite worth it to actually go ahead and get that antibody test because it doesn't give you any answers.
Aha, that's good to know. So Katrina Haslett wanted to follow up about the pregnancy question, so please.
Hello, my name is Dr. Katrina Haslett. I am a local OBGYN who is a generalist, so I do deliver babies on a daily basis. And I want to emphasize to all the pregnant ladies, we do currently recommend you get the vaccination. The reason for this is that we know that the vaccination in pregnancy can be very severe. And we're finding that a lot of the pregnant ladies who are positive, sometimes we don't know they're positive when they present. They get really sick. They get sick enough to lose their lives. They get sick enough to lose their babies. They get sick enough to deliver their babies at a time where their babies have to struggle to make it, if they do so. And it really hits home when you ask, when should I get it? When should I not get it? Get the vaccination. If you're pregnant or not. If you're pregnant, you get it because you want to protect your baby and your life. You need to be here to take care of your children, number one. Number two, you get the vaccination so you don't spread it to your children. You don't spread it to your grandparents. You don't spread it around. And we know that getting the vaccination is much, much worse. It is devastating compared to the vaccination. So get the vaccination. You put on your seatbelt, you get vaccinated. It's just that simple. Thank you.
All right, Dr. Haslett, I'm going to call you Reverend Haslett because you preached that thing. So thank you for sharing with the audience on that. That does conclude all of the Q&A. I want to thank all of our panelists for sharing this information and for you, our community, for being a part of this important webinar. I do encourage you to register for the 2 upcoming webinars. The next one is April 21st and then followed by May 19th. So please attend both of those, spread the word, let your community know that this information is available from us so that you can get the people that have the answers, that look like you, that think like you, that know you, that can give you the information you need to know. I also want to thank our sponsors, Delta Sigma Theta Sorority, Inc., Nevada Minority Health and Equity Coalition, UNLV School of Public Health, Dr. Katrina Haslett, the Health Plan of Nevada, and Compassionate Las Vegas. And of course, thank you to Commissioner and Congresswoman for being on and sharing those words with us. I want to remind you that you are not just a drop in the ocean, you are the entire ocean in a drop. Understand that what you do matters. You are important, and we need you to stay healthy. So until the next time, spread compassion, not COVID. We will see you again in April. Thank you again for completing our survey, and enjoy your evening.